the regimen DC alone in randomized phase 2 trial. TTP was 5 months. The median overall survival was 9 months. They suggest that this combination may be a potentially effective treatment in a neoadjuvant settings, where a rapid tumor reduction before curative surgery is important. FNCLCC trial, this phase 3 trial was done between surgery alone and perioperative chemotherapy group for resectable gastroesophageal adenocarcinoma. Chemotherapy given with cisplatin and infusional fluorouracil. 5-year overall survival rate was 38% in perioperative group versus 24% in surgery only group. This study was terminated prematurely for poor actuarial. So, some home messages for perioperative chemotherapy that 5-year projected overall survival with float is 45%. Therefore, there is still more work to improve the more survival. Now we will discuss with adjuvant chemotherapy. ACTS trial adjuvant chemotherapy for gastric cancer with S1 was performed in Japan between surgery only group of 530 patients and surgery followed by oral S1 and oral fluoropyrimidine of 529 patients of stage 2 or 3 gastric cancer. They showed that 3-year overall survival rate was 80% in S1 group and 70% in surgery only group. The X trial also they showed published their 5-year survival rates. The X gastric trial was published in their 5-year overall survival 71% in S1 group and 61% in surgery only group. The disease-free rate at 5 years was 65% in S1 group and 53% in surgery only group. So they recommend that postoperative adjuvant with S1 was confirmed to improve overall survival and disease-free survival in patients with gastric 2 or 3 gastric cancers who undergone T2 gastrectomy. Now in classic trial, phase 3 randomized clinical trial on gastric cancers with adjuvant Zelox after D2 gastrectomy performed in 37 centers in Korea, China, Taiwan in stage 2 to 3B gastric cancers. Adjuvant chemotherapy was given with orally capecitabine and IV infusional oxaliplatin for 6 months. Another group was surgery alone, 515 patients. Surgery plus chemotherapy were 520 patients. 3-year disease-free survival were 74% in chemotherapy plus surgery group versus 59% in surgery only group. The Summit trial also did not achieve its primary endpoint. 3-year disease-free survival was 57% in adjuvant paclitaxel followed by oral fluoropyrimidine versus 55% in 5-AU leucovorin group. ITACA's inter-group trial of adjuvant chemotherapy in adenocarcinoma of the stomach was a randomized trial on adjuvant treatment with FOLFIRI followed by docetaxel and cisplatin versus 5-AU leucovorin for radically resected gastric cancer. No statistically significant difference was detected for both disease-free survival. 5-year disease-free survival was 44% for both arms, and overall survival was 51% in 5-AU leucovorin and 50.6% in experimental arm. Now there are some debate chemotherapy versus chemoradiotherapy. ESOPAC will answer the best one between chemotherapy and chemoradiation. This study comparing perioperative chemotherapy with plot protocol versus neoadjuvant chemoradiation according to cross protocol in localized resectable adenocarcinoma of esophagus and gastroesophageal junction. We have to wait up to 2024 it is hypothesized that perioperative chemotherapy will result in increased overall survival. Top Gear trial will give us the answer, the question perioperative chemo versus perioperative chemoradiotherapy. Top Gear was randomized phase 3 trial between ECF chemotherapy with or without preoperative chemoradiation for resectable gastric cancer. ECF alone group taken 3 cycles NACT, while in chemoradiation group taken 2 cycles of NACT followed by chemoradiation. Both groups received 3 cycles of ECF chemotherapy. The proportion to proceeding surgery 90% in ECF group and 85% in chemoradiation group. They recommend preoperative chemoradiation can be safely delivered to vast majority of patients. Intergroup 0116 556 patients with resected adenocarcinoma of the stoma or gastroesophageal junctional cancers were randomly assigned to surgery plus postoperative chemoradiotherapy or surgery alone. The adjuvant treatment consisted of fluorouracil plus leucovorin followed by radiation. The median overall survival in the surgery only group was 27 months as compared with 36 months in the chemoradiation group. Gastric gastric group meta-analysis, global advanced adjuvant stomach tumor research international collaboration group done a meta-analysis of all RCTs for overall survival and disease-free survival. There are 1,000 deaths among 1,924 patients of chemotherapy group and 1,067 deaths among 1,857 patients of surgery group. They showed that adjuvant chemotherapy was associated with a significant benefit in terms of overall survival, and 5-year overall survival increased from 49.5% to 55.3% with chemotherapy. There are some negative uh, trials. CalGB 80101 trial was done between adjuvant chemoradiotherapy with ECF and adjuvant chemoradiotherapy with 5-leucovorin after curative resection of gastric cancers or gastroesophageal junctional cancers, stage 1B to 4A. They showed 5-year overall survival rate were same, 44% in both arms, but disease-free survival was 39% in 5A2 and leucovorin arm, whereas 37% in ECF arm. So, after a curative surgery of gastric cancer or gastroesophageal junctional adenocarcinoma, postoperative chemoradiotherapy using multi-agents regimen of ECF before and after radiotherapy did not improve survival compared with standard 5-leucovorin before and after radiotherapy. Another one, ARTIST trial was a phase 3 trial comparing capecitabine plus cisplatin versus capecitabine plus cisplatin with concurrent capecitabine radiotherapy to complete resected gastric cancers with G2 lymph node dissection. 3-year disease-free survival was 78% in chemoradiation group and 74% in chemotherapy group. Overall, there was no significant difference in disease-free survival with additional radiotherapy to chemotherapy after G2 resection in postoperative settings. Another one, critics trial was international open label randomized phase 3 trial in stage 1B to 4A esophagogastric cancer. It was taken for comparing perioperative chemotherapy versus chemoradiation after surgery and preoperative chemotherapy for resectable gastric cancer. In chemotherapy group, 3 cycles NACT, 3 cycles adjuvant chemotherapy with ECO or ECX. Trial showed median overall survival was 43 months in perioperative chemotherapy group and 37 months in chemotherapy plus chemoradiation group. So postoperative chemoradiation did not improve overall survival compared with postoperative chemotherapy in patients with resectable gastric cancers. Here is a trial of adjuvant chemotherapy plus G2 dissection in Taiwan. 534 patients with stage 3 gastric cancers after G2 surgery followed by adjuvant chemotherapy were enrolled for the study. They showed overall survival 30.7 months, disease-free survival 26.4 months. The intrinsic factor, gastric cancer exhibits striking inter-individual differences in disease aggressiveness, histopathological features, and response to therapy. Most patients with gastric cancers today are managed like with one-size-fits-all approach. To escape this approach, this study was done in 521 patients in Singapore, Australia, and South Korea. Genomic expression signature clearly defining two major intrinsic subgroups of gastric cancer: genomic intestine and genomic diffuse. Their subtypes are found to be significantly associated with Lawrence histopathological intestinal and diffuse subtypes. Overall concordance between the intrinsic genomic subtypes and Lawrence histopathologically classification was only 64%. Gene expression pattern of gastric cancer predicts survival and response differently to chemotherapy. Patients with genomic diffuse cancer had worse survival outcomes compared with genomic intestine. The intrinsic subtypes exhibit distinct in vitro response to chemotherapy, like genomic intestine significantly more sensitive to 5-FU and oxaliplatin, but resistant to cisplatin, whereas genomic diffuse more sensitive to cisplatin. According to NCCN guidelines, tumor size T2 or higher with any lymph node recommendation is perioperative chemotherapy or preoperative chemoradiation in medically fit and resectable tumor. And in case of surgically unresectable tumor, chemoradiation or systemic therapy is recommended. According to MD Anderson Cancer Center, the recommendation is in case of tumor size T2 or more without lymph node involvement, esophagectomy with lymph node involvement CCRT in gastroesophageal junctional cancer. In case of gastric cancer, tumor size T2 without lymph node involvement, recommendation is surgery followed by chemotherapy. But with lymph node involvement, surgery followed by chemotherapy and chemoradiation. Now, what's new in perioperative chemotherapy? In PDG trial, chemotherapy, surgery, and chemotherapy versus surgery plus chemotherapy is progressing. Their median survival was 37.4 months, 66 in chemotherapy, surgery, and chemotherapy group, 66% in surgery and chemotherapy only group, compared to surgery and chemotherapy arm was 60.2%, and hazard ratio in living was 0.84. Result trial is a three-arm trial showing perioperative shock is superior to adjuvant Xelox, while postoperative shock is non-inferior to adjuvant Xelox for locally advanced gastric cancer after T2 gastrectomy. It provides the evidence of perioperative shocks in locally advanced gastric cancers. CODIS-19 trial was between adjuvant chemotherapy versus perioperative chemotherapy for resectable gastric signet ring gastric cancer. R0 resection rate 88% in perioperative chemotherapy arm, compared to adjuvant chemotherapy arm 78%. Median overall survival 39 months versus 28 months. Overall survival at 2 years 60% in perioperative chemotherapy arm versus 53.5% in adjuvant chemotherapy arm. This trial meets its primary endpoint and plot is recommended for signet cell gastric cancers. My acknowledgement is some slides are taken from eCME preceptorship training on gastric cancer or gastroesophageal gastric cancers. Thank you all for patient sharing.
Thank you, Dr. Abdullah Al Mamun, for sharing all the updated information regarding the gastric and junctional cancer. Now, I would like to request Shorna to post the poll, and we will discuss on poll by poll with our overseas faculties. Shorna,
Yes,
Arman, Mamun, can you please stop sharing?
Yeah.
Thank you. Shorna, you can, yes. So I would like to request all the participants to participate in the poll, and later we will discuss on this question with the audience and our faculties. Okay, Shorna, stop the poll over here. Now I would like to request to our today's presenter, Dr. Mamun, what is your decision regarding this question? Locally advanced stomach cancer, and we have
Localized gastric cancers at pylorus adenocarcinoma,
yes,
the MSI high.
MSI high, yes.
MSI high. So MSI high, if that is, should be genetic counseling and chemotherapy uh, would not satisfy the desire rather than the side effects of chemotherapy.
Okay. Why I have bring this question over here? So from your presentation with the MAGIC trial and the plot 4, we have got an idea that the perioperative chemotherapy is the standard of choice. So is there any group who we really avoid this perioperative chemotherapy, or this is a standard practice to all, or rule of thumb? So I would like to request our overseas faculties, Dr. Jahid Khan, can you please give your inputs regarding these issues? So is there any role of MSI study to take the decision before perioperative chemotherapy? Dr. Jahid Khan.
Thank you, Dr. Shumon. Really tricky question. So the first thing is that MSI status or MMR status has not been established yet to decide the treatment in the new adjuvant or preoperative setting. Okay, there is no standard guidelines to support it. But we know from the colorectal trial, the MSI high patients did not respond very well to neoadjuvant chemotherapy. Okay, so that was the Foxtrot trial. However, that's not the issue today. So, but what we do know overall, the MSI high or deficient MMR patients, they have a less chance of responding to chemotherapy. But let's put that to one side from what we already know. And what we already know, this is a young patient. So I'm assuming this is an otherwise fit patient. Number two, this is a locally advanced gastric cancer. We haven't been given the T and N status, but I would assume there's at least a T4 tumor, maybe N1, or this is a T3, N2 tumor, okay? So this patient has got a very high chance of developing early metastatic disease, okay? And even if it isn't, this patient has got a chance of becoming an inoperable cancer very soon. So what you really need to do is to throw everything at it to try to downstage it, number one, and also try to reduce the risk of early recurrence. So I think overall, I would go for A, because with the available evidence that we have, I'm afraid this is the best choice for this patient.
Okay, let me discuss Dr. Jahid Bhai. So as from discussion from the MAGIC trial and the classic trial, the two, as you know, the two classic trial who has established this adjuvant established. But when we go through the MAGIC trial, in MAGIC trial, 19 patients were MSI high, and the classic trial, there are 32 patients with MSI high. And among the 51, they have responded very poor with perioperative chemotherapy in the MAGIC trial. And in the classic trial, with adjuvant therapy, they also reported with very poor outcome. And they finally concluded that only surgery resulted in a very good outcome compared to chemotherapy, even if given in pre-op or post-op settings. That's why I have asked this question here. So with this evidence, though it is retrospective, though it is not a very calculated study, but this information is giving us that information that those who are MSI high, why did they are not good candidates for peri-op or adjuvant chemotherapy? So that's
So,
the discussion.
so again, that's a good question. So right now, this is only an information that hasn't been statistically or robustly proven through more patients. So to prove that hypothesis, we need actually maybe looking at the New Aegis trial, where we'll probably have more translational data. Because if you talk about Magic Trial is an awful trial. If you look back, there wasn't any EUS, okay? There wasn't any laparoscopy for many patients. So many patients, we don't even know what was the exact staging of the trial, the patients. So as I've said, right now, what you've said that we know that MSI high patients do not respond very well to standard chemotherapy. We know that, but is to trying to get enough evidence for us to say that we should not be giving chemotherapy. I think that's the hard call. And that's why no country, no international guidelines committee has yet to come back and say, do not give chemotherapy to these patients. You've got a 42-year-old patient, he's got a locally advanced cancer. Your window of opportunity to treat this patient is really very small, okay? So if you go for the other thing is we need to keep in mind that in the Eastern or Oriental Asia, they have a propensity to go for D3 surgery, which has not been recommended and which is not in practice in the Western Europe, in North America. So you could say that in the West, in the Oriental patients, whether the D3 offers a better chance with surgery, it's another controversy. Okay, another question that we do not know the answer, because D3 will never be practiced in the Western world. It's a very morbid surgery, but obviously Japanese surgeons has got a much better experience and a long-lasting experience to do those kind of surgery. So that's another question. And again, if you go to the Asian trials where there is a heavy bias on the adjuvant chemotherapy rather than anything neoadjuvant, and that is again based on the fact that they do a far more extensive surgery than the Western population. Okay, so again, to answer the question, we do not have enough evidence in hand right now what is the best approach for MSI high. But again, if I've got a patient right now in front of me who's 42, who's got a locally advanced gastric cancer, who is otherwise fit for a multimodality treatment, then I would definitely go for the chemotherapy, the perioperative approach. As I've said, that I can't tell this is the best approach, but this is what we have in our hand right now. That will be my answer.
So thank you, Zahid bhai. So till date, the standard is perioperative chemotherapy with the evidence we have had. But we can consider this MSI high, and we can have this second look regarding our approach. So Shorna, can you pose the second question? I would like to request every participant to answer in the poll. So thank you, Shorna. So Mamun, at first I would like to ask you the question. What is your pick?
65 years old female patient, ECOG performance status 2 with locally advanced stomach cancers presenting with gastric outlet obstruction. Only liquid can pass. As the gastric outlet obstruction, nutrition maintain should be considered first. If we think nutrition maintain first, so surgery is the first treatment option followed by adjuvant chemotherapy.
So your decision is to answer A, okay? Right? Surgery. Thank you. So why I have raised this question? In our routine daily practice, we have got a number of patients with this scenario. At this time, as oncologist, I am very in favor of giving neoadjuvant chemotherapy to see whether it is responded or not. So, but at the same time, his or her physical conditions is not fit enough to go for adjuvant chemotherapy, and might be this is a time losing procedure which ultimately result in a poor outcome. So, what's your decision regarding this, Dr. Jahid Khan?
So fantastic. This is a real world scenario, isn't it? It's not a spring chicken with performance status 0 or 1, where we would see in a trial patient. Okay, so you could say just on the basis of performance status, this patient would not be suitable for flood. However, let's just try to get some more information. Okay, so you haven't mentioned any comorbidities. So on that basis, the patient has got a gastric outlet obstruction. So I would imagine the reduced performance status is due to the gastric outlet obstruction. Okay, the patient doesn't have any metastatic disease. So I would really would like to give a little bit of fight for this patient. I would go for B, that I would try to help the nutrition, and I would try to see whether it's a jejunostomy, whether TPN, in whatever way you can improve the nutritional status and the performance status of the patient. And then you decide whether the patient is still going to be fit for the multimodality treatment, which is perioperative treatment plus surgery. Obviously, your other thing you need to keep in mind is whether this patient is actually anesthetically fit for surgery. Because as I've said, we do not have any comorbidity status. So again, if I say what will happen in our MDT, the patient will be assessed by the surgeon, the patient will be assessed by the anesthetist, and the patient will be seen by the oncologist, because each team or each person will make their own individual assessment, what is this patient fit for, okay? And if we assume that this patient hasn't got any comorbidity, the patient is otherwise fit for general anesthesia, the patient is fit for no contraindication for chemotherapy, then yes, I would go for the nutrition first and then decide what is this patient fit for. Now, A is actually a reasonable option. Again, if you consider the Oriental Asia or East Asian countries where adjuvant chemotherapy is actually a reasonably standard approach, you could go for operation and then give adjuvant chemotherapy in the form of Kpox or even S1, but that's not the practice in UK. Was my answer clear enough?
Yes, yes, I got your point. So you are very, very famous for neoadjuvant chemotherapy, as I have got. So even you are with the feeding jejunostomy or any kind of nutritional support, you will go for neoadjuvant chemotherapy if possible. If not possible, then it is
if
surgery.
possible.
Yeah,
yeah.
But the supplementary question: why are you in so much favor for neoadjuvant chemotherapy? Does neoadjuvant chemotherapy going to give you any overall survival advantage than adjuvant chemotherapy?
Okay, so there isn't any trial which has compared so far neoadjuvant chemotherapy plus surgery versus adjuvant chemotherapy alone. So to answer your questions, whether neoadjuvant chemotherapy and surgery has got an edge over the surgery plus adjuvant chemotherapy, the answer is we don't know. However, there's two important biological behavior of stomach cancer we need to keep in mind. It's not only for gastric cancer, it's also for esophageal cancer, that actually your best window to give any systemic treatment is before the surgery, because the upper GI surgeries are such morbid surgery that more often the patients are not fit for adjuvant treatment in future, okay? And if you look at the MAGIC trial, if you look at the fraud trial, you'll find out that how many patients were non-compliant with the adjuvant treatment. That will give you the answer, okay? The second thing is, remember that the upper GI cancer relapse very early, and which means that even a small cancer can develop micrometastatic disease very early, which is not visible on any preoperative staging. So again, putting these two information, one is that it's more difficult to give adjuvant treatment in upper GI patients. Okay, so you've got a better window of giving them systemic treatment before the surgery. And number two, that they have got a very early relapse behavior, and you would like to avoid that, because what's the point of putting someone through a major operation like an esophagogastrectomy or a gastrectomy? Because it takes up to 2 years to get the quality of life back after a surgery like that. And these patients then relapsing within 6 months of their surgery, actually, we have done worse for them. We have caused harm to them. So the overall practice in the Western world, and I would imagine that should be the practice anywhere in the world, that if possible, to try to give maximum treatment, the neoadjuvant treatment. And yes, if the patient is fit after the operation, then of course we can consider some adjuvant treatment.
Thank you, Zahid Bhai. Even in Asia, you know the China trial, result trial, they have tried to get the answer that adjuvant versus neoadjuvant. And though the mature overall survival did not yet to come, but the disease-free survival, 3 years disease-free survival, they have shown a better result in the neoadjuvant arm. The 3 years disease-free survival, they have got 8% survival overall advantage. But let us see the overall survival data. Now it is on disease-free survival.
Yeah. Now,
So
I'm sorry, just to interrupt you. There is one big issue. I'm not going to say this is any kind of political or racism, but there is a bit of reluctance to accept any trial which has only been done in the Oriental Asia and to be used that straight away in the Western world. And one of the best example for that S1 is not used in the Western Europe or North America. And the other thing is, remember, in the upper GI trials, some of the early immunotherapy trials were done in Eastern Asia, but they have not got straight away license in Europe or North America for the same reason that there is some reluctance to accept that data straight away. And also there is some kind of belief that maybe there is something different in the demographics in the Eastern Asia and the Western population. And again, the only verifiable fact that I can mention that the surgery in Eastern Asia is far more complex, far more invasive than Western Europe. So these are the factors in play, and which makes any evidence to accept straight away in the Western Europe that comes from the Eastern Asia. So that's all I can tell, I'm afraid.
thank you. That is the issue that was asked by Dr. Kamal Bhai. And he was asked this question in the chat box. So why S1 is only giving better result in Japanese population? I hope we will discuss it later.
Yeah.
So Shorna, can you please pose the third question? So thank you, Shorna. So Dr. Mamun, what's your decision?
Instead of perioperative approach, what are the situation in gastric cancers when you will consider surgery first? The voting results are 33%, 33%, and 33%.
And these are all equal.
Tough question and tough decision. I think the discussion have been discussed earlier. I think surgery is the first option in obstructive tumor. Any obstruction is a surgical emergency. If there is no contraindication or comorbidities that deny to surgery, I think obstructive tumor should be surgery first. And the second option, MSI high or MMR, the surgical treatment required, followed by immunotherapy or targeted therapy.
Thank you, Mamun. Dr. Jahid Khan, sir, please.
Okay, so I think our practice in UK, the only acceptable answer right now would be A, which is refractory tumor bleeding, because you can manage obstructing tumor by alternative nutrition strategy. And also for C, as I've said, there is no proven benefit yet in the Western world data that you should straight go for surgery. So from our practice in UK, I will only go for A.
So thank you. Probably that is the question we have already discussed. The intermediate bleeding, probably the worst scenario whom we can consider the surgery first. Otherwise, but the last two answers are yet to discuss, though there are some disputes. But we have got the idea. Now we are going to take some questions from the chat box. So Dr. Arman Reza, can you please ask your question directly to our overseas faculties? Dr. Arman.
Yeah, thank you, Dr. Shuman, for giving me the opportunity to ask the cancer. So I have two questions actually. In case of adjuvant setting of gastric cancer, what is the preferred chemotherapy protocol? Because we have seen that Dr. Mamun already showed us that so many protocols. So which is the preferred protocol for adjuvant setting? And my second question is it okay that if we want to avoid radiotherapy in case of gastric, local advanced gastric cancer, we can administer perioperative chemotherapy? Or what are the criteria for selecting patients for perioperative chemotherapy in case of local advanced gastric cancer? Actually, these two are my question.
Is it to me? Okay. So in UK and Western Europe, the radiotherapy, adjuvant chemoradiotherapy has never been accepted as an approach. Particularly in UK, we never adopted that as an approach. So our approach has always been perioperative chemotherapy. So in UK, if the patient is fit and no absolute contraindication, then our approach would be neoadjuvant chemotherapy with FLOT, surgery, followed by adjuvant FLOT chemotherapy. This is our standard of care. Now, there will be situations, as you've seen, that if there's a bleeding tumor, the patient might straight go for operation. And in that case, the question is that what is the role of adjuvant chemotherapy? So you could say that how do you, okay, let's just some prognosticate the tumor and look at the clinical evidence. So as I've said that other than the Eastern trial, Eastern Asia trial, there is no Western Europe trial or the North American trial to say any comparison between the neoadjuvant and adjuvant trial. But this is an extrapolated idea also from the classic trial where you have used K-pox as an adjuvant treatment. We would use still FLOT as an adjuvant treatment if the patient is fit. If the patient is not fit, then you could consider K-pox or FOLFOX as an adjuvant treatment. But this is not something that we practice very commonly in UK. So again, to summarize, if the patient is only went for the surgery for whatever reason, and if it is a node positive tumor, if it is a bulky T2 tumor, or any, then we would consider adjuvant chemotherapy for them. And in the ideal situation, it should be FLOT. If the FLOT is not suitable, then we'd go for K-pox. And chemoradiotherapy, it is not in practice at all in UK. Under no circumstances we are using chemoradiotherapy in UK. So that's my answer would be no. And if you go back to intergroup and CalGB data, which were the two adjuvant chemoradiotherapy trial, even the chemotherapy protocol is very different. Intergroup trial is now completely obsolete. I don't think other than in a presentation like this, nobody actually practices intergroup evidence anymore. But maybe the CalGB is a little bit more up to date, a little bit more acceptable. But as I've said that we do not accept it in UK. There is a bit of historical background for adjuvant chemoradiotherapy in USA. I would imagine that you should know. Then in USA during those trials, there was no MDT approach. And what it meant that if anybody diagnosed with a gastric cancer, the surgeons would pick up and straight go for operation. Okay. And that means after the operation, then it is dumped on the oncologist. Okay, we've got a patient. The patient has got node positive gastric cancer. What shall we do now? And then led to this intergroup and the CalGB trial. Okay, the operation is done. We have lost the opportunity to provide any neoadjuvant treatment. The only thing we can do now is adjuvant treatment. And they thought, let's throw everything at it. Let's put chemotherapy and radiotherapy together to see if we can get the best outcome. But whereas in UK and Western Europe, we always considered multidisciplinary approach. And we felt, remember we talked about the two particular behavior. One is that you've got your best chance to give systemic treatment in the neoadjuvant setting, and these patients will regardless relapse quite early. So that has become our approach. That I'm afraid I have not seen in my, how long has it been on in oncology? Probably about 15, 20 years in this country. I have not seen use of chemoradiotherapy in gastric
That
cancer.
is the problem in our country actually, that most of the patient came to the oncologist after the surgery. So that is the issues.
So I guess your choice is whether you give chemoradiotherapy with so many different regimes, which one to choose for, or you can go for more simple approach, which is given post-operative chemotherapy only. And if it is my patient, I'm seeing someone today in UK, that will be my advice, to give post-operative only adjuvant chemotherapy, not chemoradiotherapy. But I'm actually keen to hear from the other peers here, Kamal Bhai, Professor Hai, and anybody, what they're doing in this situation.
Okay. Okay, we will give that time. Let me complete the question first. But Dr. Jahid Bhai, I have a supplement question. So you are sitting in an ideal world where you can expect a D2 resection or a complete resection. So in the Bangladesh, very rarely we could see a D1 resection. Most of the time it is D0 resection. So in this context, still you believe in chemotherapy only, or you will consider CTRT?
I'm afraid I don't know the answer. Because anything less than D2 is completely unacceptable in the Western world. So if you haven't got even the perigastric nodes removed, well, I'm afraid this patient is going to relapse. 100% patients is likely to relapse within a very short frame of time. You have to do something. So I don't think, if you go by evidence, there's nothing wrong going by the CalGB evidence and giving adjuvant chemoradiation. There's nothing wrong with that. It's absolutely fine. But we, in an ideal world, I'm afraid that's, I would give at least, doing something is better than nothing. Okay, so whether you give adjuvant chemotherapy or whether you give for adjuvant chemoradiotherapy, I don't think that makes a big difference. Big difference is if you can give something to the patient after the surgery. I hope that makes sense.
Okay. So in a surgical situation where we are going to get a less than D2 resection, the normal routine guidelines are saying that you can offer concurrent CTRT. So that's why here in Bangladesh we are going to promote these things. So even if
I mean,
less surgery,
you are going by accepted evidence. There's nothing wrong with that. That's nothing wrong with that. So that's absolutely fine.
Dr. Shahida Alam. Dr. Shahida Alam.
If the margin is positive.
If the margin is positive, then what would be your approach? Lima Park.
Okay, Lima. So I think your question.
Okay, we have got your point.
Yeah. Okay. So let's look at where the margin is likely to be positive. Is it in the proximal or distal margin, or is it the circumferential margin? So more often, I don't think I have seen anything proximal or distal margin positive these days with a surgical technique. The only time margin comes back positive is the circumferential margin. And in circumferential margin, I think the scope of chemoradiotherapy, I have not seen any of my clinical oncologist colleague recommending chemoradiotherapy or adjuvant radiotherapy. Our approach is still the same, giving adjuvant chemotherapy only.
Thank you. Now, Limapa, sorry, regarding your poor connectivity, we cannot hear you properly, Limapa. You can ask your question in the chat box. We can discuss it later. So thank you. And now it's time to our academic secretary, Dr. F.M. Kamaluddin sir, to say a few words regarding today's discussion, his inputs, and if he has any questions to our overseas faculty. Dr. F.M. Kamaluddin sir.
Thank you, Shumon. It was interesting, and it was always good to listen to you, the new generation, and learn how things are moving. So if I come to the first point that you brought very intelligently about the MSI. Well, the way we are not considering MSI, but you see, there was a publication in JCO in 2019. There was a meta-analysis of around 1,500 plus patients, and on all the 4 studies, including MAGIC trial. And that meta-analysis concluded to consider MSI now as an issue in stomach cancer. Not only that, and they have shown that, as you mentioned, that surgery was doing fair. I mean, on that meta-analysis, if somebody want to take a challenge of excluding chemotherapy, well, you cannot just ignore it. As Zahid said, this is not a clean-cut recommendation, but maybe we don't know, it may come up. Regarding the perioperative chemotherapy, yes, FLOT is the great protocol we all know, but personally, in my experience, it is very difficult in our country to continue FLOT, and that's why I put a note on the chat box that in our country there is a common practice of, I mean, we do it our own. I mean, without any definite data, we modify our dose. Nobody can tell you how. We make our own consideration and modify the dose to make it acceptable to the patient. And we don't know whether we're doing harm or good, because as we know, the ESCO don't allow to modify the dose without any definite evidence. So in the name of poor nutritional status or socioeconomic condition, sometimes we are doing some modification of the dose, and I don't know whether we're doing harm to the patient or not. So FLOT is sometimes challenging, but still I think Xelox or Capox is a good friend of us in our region. But we wish we can do FLOT. Another thing, Zahid, what you said about the nutrition, what Shumon mentioned, unfortunately, we are not very much accustomed about the feeding tube story in gastric cancer, even after surgery. So we really struggle for nutrition because these patients are inherently, they are very weak. And after treatment of surgery or chemotherapy, they struggle more. So the disease, surgery, chemotherapy, and lack of nutrition, all this make patient very weak. I know in your country, if a surgery is done, definitely they put a feeding tube. And it is a mandatory component, but hardly it works here. So this is another challenge. And lastly, regarding the, it was interesting to listen to you about the chemoradiotherapy. I have a bit different thought about that. Maybe I had some small exposure in transatlantic, that's why, because they are a believer of chemoradiotherapy. You know, people are biased where they are trained. So what I still see that there are some RTOG data that when there is a node positivity and there is margin positivity, yes, I agree, circumferential doesn't work. These two areas, there are some survival benefit with chemoradiotherapy. But the question is, you know, when we do the adjuvant chemoradiotherapy, we more focus on the nodal station rather than the margins. So it is assumed that this chemotherapy along with the radiation is taking care of some of the nodal relapse. But as you said, there are wonderful data of perioperative chemotherapy, and you are fortunate to have such a wonderful surgery. So you are enjoying, but you know, even in Western world, in opposite part of Atlantic, still there are some big believers who are practicing chemoradiotherapy. Even you said that this McDonald's trial regime, yes, I agree. But you need to understand that McDonald's is the first breakthrough. 26% survival that was they have shown, when there was 36% discontinuation of the patient for the toxicity. And that has been compromised. What we do, we only use capecitabine. When I do adjuvant chemoradiotherapy, I use capecitabine and radiation, and it is fairly tolerable. And if you look at the Tata Memorial Hospital data, you can see, Shumon, there are quite good reference of giving adjuvant chemoradiotherapy in node and margin positivity, and they are good survival. So in oncology, I'm not going to say nothing is wrong and nothing is right, but whatever we should do in this platform, we should discuss that it should be guided by evidence. And it is good to listen to you people who are from this soil, living in a different area. So you can make a mix, because when we listen to a pure European, he cannot understand our limitation. So it is good to listen to you and shared the experience. And I think, as Mamun showed, that no study have shown a very good survival of stomach cancer. So there is a big way to go with stomach cancer, maybe immunotherapy, and something more will come up and it will give us good future. But today, Shumon, I would say that we need to work hard. Our participation was one of the most poor among last 6 months. So I think something is wrong somewhere. We need to work on it. But it was a wonderful discussion. Congratulations to the Mamun for the nice presentation. And Zahid, thanks for giving the time and joining us in the participation. And finally, as always, I congratulate you for wonderful.
Just one thing I need to inform, and regarding this poor participation of today, probably this lockdown issue and the huge traffic jam over the Dhaka city. I have called some participants over there. Some of them are paid to reach their distant location. So probably that's why we have seen a poor participation. Hopefully it will be over in the next session.
From the organizer's point, I cannot allow you to breathe. When I see a flaws, I need to push. That's what I am doing.
Thank you.
Can I just say one thing? Oh, sorry.
Please.
Someone is trying to ask a question, I think. I'll let that go ahead.
All right. You go on, Zahid.
হ্যাঁ ভীমা বলো
না তুমি বলো আমি কথা বলছি
আচ্ছা সো আমি যেটা বলতে চাচ্ছিলাম যে যেটা ডক্টর সুমন এবং কামাল ভাই দুজনেই বললেন যে MSI high status there's one statistical fallacy I need to keep everyone to be aware. So there's two ways we can look at an information whether it's going to be useful in your clinical decision from a trial or not. So you can have a retrospective analysis and you can have a pre-planned subgroup analysis. And there is a big difference between the two. When you do the pre-planned subgroup analysis, you always keep in mind that you will have the statistical power to prove what you're saying is right or wrong. Okay, so if you say that if you're going to put MSI high status in your pre-planned subgroup analysis, then you have to make sure that you've got enough number in your trial to be randomized in the both arms to give you the answer. But if you go for only retrospective analysis, okay, the trial is done, the statistical analysis is done, now you're finding in information and you're wondering, is it significant or not? The answer is, I'm afraid it's not. No matter how it wonderfully says that the chemotherapy doesn't work, it is a retrospective analysis. It is not a pre-planned subgroup analysis. So I'm afraid based on that, you cannot make any clinical judgment on that. I hope it clarifies the issue. So I'm not saying that MSI high status we should be completely disregarding, but my answer would be watch the space. I'm sure in the future trials where this will be included as a pre-planned subgroup analysis and we'll know the answer.
Zahid, let me respond to your comment. I totally agree with you because the meta-analysis they have done is on a retrospective analysis of 4 study. I totally agree. And another thing is another weakness of the meta-analysis is less than 10% of the study population was, because the percentage of MSI high is not very high in stomach cancer like colon cancer. So they have observed it near about 7 point something percent. It is below 10%. So that was another weakness. But interestingly, they found this thing. So we don't know, as you mentioned, maybe from these findings, somebody will start a pre-planned study and they may find out a link. But I agree with you that this cannot be a robust logic to take it. But if somebody wants to sell it, they can bring up an issue to discuss. And definitely, I mean, personally, what I tell from our country perspective, we should be always sticking to the guideline, not lending to some data or some recommendation. Because unless it is adopted to a guideline, we are not very much secure because we are not in an academic center to tell that we are doing some research or blah, blah thing. So if something goes wrong, we cannot really challenge it. So we should wait till it comes to the guideline. And till then, it is good to listen, good to discuss, but difficult to apply in clinical practice. I totally agree with you, Zahid. But what I appreciate that people should be knowing that these things are happening, that these are coming up, and this could be an issue. Say somebody in Cancer Institute, they may take up that they want to do a study, make a prospective study to watch what is the outcome. So that can be an issue by looking at the 2 arm with MSI high and to see the effect of chemoradiotherapy in adjuvant setup. That can be done. So totally agree, no disagreement, Zahid. But you know why we bring this controversial issue? Shumon intentionally brought it because if we only look at the arrow of NCCN guideline, we will not know what is happening above the arrow. So we know the fluctuation curve and we should know what is happening. So we should be prepared that next year the arrow may change and something may come up. Thank you.
Absolutely, absolutely.
জাহিদ ভাই আমি জাস্ট আমার প্র্যাকটিক্যাল লাইফ এক্সপিরিয়েন্স শেয়ার করতে চাই। আমি আমার লাইফে 4 থেকে 5টা অল্প বয়সী পেশেন্ট যাদের বয়স 25 থেকে 30 তাদেরকে পেরিঅপারেটিভ কেমো স্টার্ট করছি। বাই দিস টাইম ফার্স্ট সাইকেলের পরে ডিজিজ প্রোগ্রেস করছে এবং আলটিমেটলি আমি তাকে ডেফিনিট সার্জারি করতে পারি নাই। আই হ্যাভ টু ল্যান্ডেড উইথ প্যালিয়েটিভ সার্জারি। দ্যাটস ওয়াই আই এম রিয়েলি কনসার্নড, ইজ দেয়ার এনি গ্রুপ where these biomarkers can really guide us whether, because we are not going to give the chemotherapy only, we are at the same time we are going to lose some time. So that is why I am really looking for some biomarkers whether we can update those who are going for preoperative chemotherapy or not. So this is not the MSI only, so I am desperately looking some biomarkers whom we can really guide to select this preoperative chemotherapy or not.
And I can tell you that we are not in any different situation than what you are. So right now, there isn't any biomarker to help us to guide this decision, I'm afraid, even in the Western world. And I can understand that I work in a privileged situation, but in spite of that, upper GI is a horrible cancer. And vast majority of our patients, the real world patients, do not fit in the clinical trials performance status group. So yes, we are also trying to adapt. We are also trying to modify treatment to make sure that the patient is getting something rather than nothing. The one thing I just kept in mind, though it's not for gastric cancer, but a CheckMate 577 trial, which used adjuvant nivolumab with chemotherapy, that is something is interesting. So I mean, I only mentioned it because the MSI high status keep coming back, though the CheckMate 577 did not recruit just MSI high patients, but I think we'll be starting getting some important information sooner or later. Okay, so again, to answer your questions, upper GI cancer, horrible cancer, no matter what we do, the outcome is poor and we have a lot more to achieve. And we it's not good enough, whatever we are doing. That's the bottom line.
Thanks for the excellent discussion, because we have already crossed 50 minutes time. So thank you, Jayant.
One question to Zahid. You said that
Yeah.
Asian and Trans-Asian. But the interesting thing is what Shumon, I asked the question S1. It is not acceptable. But you know, the interesting thing is when the Western world tried with S1, it was never a positive trial. But when Japanese always tried, it was always a positive trial. So can we say that there is some genetic issues maybe in the population where it is working? Because not to be only biased. And I can tell you another thing, it is not on a stomach, but on esophagus. So we know, I mean, we all know in radiation oncology, 50.4, beyond 50.4 is not effective. But in Tata Memorial, invariably they are giving 60 gray. And their data is robust on esophageal cancer that 60 gray works. And I know one of my friends, Sarbani, she said, Kamal, this Indo-Asian esophagus doesn't work on 50 gray, it needs 60 gray. So she make a joke, but they joke with their data.
Yes,
So
yeah.
probably, you know, it is not nasopharyngeal carcinoma that we all treat in the same way. Maybe in GI, we may have some different food habit, may have something where it is not really working. So really, we don't know because, you know, in head and neck cancer, we don't have much precursor to work. But in GI, there is relationship to food, nutrition, and many things. So probably, I don't know, as Zahid said, we don't know the answer. Probably the things may come up, Shumon, that there will be some segregation of geographical distribution. You can see that S1 never positive in any Western data. Same thing they replicated. But Japanese, it is not only the surgery, they have done good surgery, but still it was negative. So I think maybe, we don't know. Similarly, I want to bring up the issue of esophagus. You see, 60 gray, can you imagine they are giving 60 gray routinely in Tata, and their data is wonderful. But there, what we read, beyond 50.4 gray, additional toxicity, nothing great. So I think this is also area, as you said, that we are looking at. Thank you.
Just to add to that, I think I would agree to that. There must be some genetic difference in our makeup. And that reminds me, the Tarceva in lung cancer, when it came out in the Eastern Asia, the data was really fabulous. but that data was not same fabulous, same fantastic in Western population. So there is still response, but not as good as the Eastern population. So I'm sure there are differences. But at the end of the day, to convince the world, the trial has to be robust. So you cannot just change the world with an institutional experience or a non-randomized data. So I'm afraid that's the way to change the world. If you want to come up with a proper randomized trial and say, this is working for our patient, and this is what we're going to do.
So thank you, Dr. Zahid Bhai. So as you know, our academic partners Sanofi, and they are always extend their hands in our any kind of scientific activities. So now I would like to request Lucky Sinha to say a few words from Sanofi. Lucky Sinha.
Thanks, Dr. Mustafa Aziz Shuman, for giving me the opportunity to provide vote of thanks. Oncology Club is moving forward with the aim and objective of improving oncological care, service, and setup in the country to ensure quality cancer treatment. In this era, Oncology Club arranged this webinar on stomach cancer. We highly appreciate your effort, and Sanofi always support and encourage this kind of activity. Dear Honorable Speaker, respected faculty, and Honorable experts, and other distinguished doctor, my dear colleagues, greetings from Sanofi, Bangladesh. I would like to express my profound gratitude to Honorable Professor A.M. Hai, President of Oncology Club, for blessing us by his gracious presence. Heartiest thanks to respected speaker, Dr. Abdullah Al Mamun, Assistant Professor, Medical Oncology, Shohid Sohrabdi Medical College, Dhaka, for his excellent and elaborate presentation on role of chemotherapy as new adjuvant therapy for localized gastric and junctional cancer. My heartfelt appreciation to Dr. Mamun for sharing all the relevant data to support his presentation. My profound gratitude to Dr. Jahid Khan, Consultant Medical Oncology, Clatterbridge Cancer Center, Liverpool, UK, for enlightening the program by his expert opinion. Special thanks to Mustafa Aziz Shuman, Dr. Mustafa Aziz Shuman, Assistant Professor, Kurmitola General Hospital, for his nice coordination and conduct the program so smoothly. Thanks to Dr. A.F.M. Kamaluddin, Scientific Secretary of Oncology Club, for taking the whole initiative to organizing the virtual program. Thanks for your kind effort and valuable comments, sir. On behalf of Sanofi, I would like to give a special thanks to all participants for their warm presence and active participation. Thanks to my colleague Shorna, Fatima Shorna, for her back-end support. With all of your cooperation, we will continue this program in future. Till then, stay safe, stay healthy. Thanks for patient sharing.
Someone unmute.
Sorry, thank you, Lucky Appa, for your nice words. Now is the time to wrap up the session, and I would like to request Professor M.A. Haisa to say a few words. But before that, I would like to inform you that our next session will be on role of chemotherapy in advanced, that means metastatic gastric cancer, and the speaker will be Dr. Asma Siddiq, Assistant Professor, National Cancer Institute.
Associate Professor.
Assistant Professor, yes. So now I would like to request Professor M.A. Haisa to conclude this session.
Before Haisa says that next Tuesday in our gynae oncology session, there will be a long session of cervical cancer real life challenges. So there will be a mix of local and foreign faculties. It's a 3-hour session from 8 to 11 p.m. I'm requesting the interested oncologists to join. It will be interesting because there will be no lecture. There will be 6 real-life scenarios that every day we face challenges, and evidence will be discussed, and the expert of local and foreign will give their comments how to overcome. And 6 periphery medical college will place those real-life scenarios. And I'm sure it is going to be a very attractive session, requesting everybody to share the news with others and join. Thank you.
So, M.A. Haisa.
Okay. Thank you, Suman, Kamal, everybody. We had a very nice afternoon today. Discussions. Thanks to Dr. Abdullah Al Mamun for his nice presentation. It's taken quite a amount of There's good amount of exercise for this presentation. Dr. My heartfelt thanks to Dr. Khan from UK. All the participants, my thanks to all the participants, and special thanks to Nafi for help. Nafi is always with us. We are grateful to Nafi for their negotiation. Thank you all very much and goodbye. Have a good day. Allah Hafiz, everybody.
Thank you, sir. Thank you, sir. So with your permission, I would like to close this session.
Just come
Till
to
then, so we'll see you in next Sunday, same time, with the new topics. Till then, stay safe. Thank you.
আজকে উইনার আছে